So I'm going to take a little shift and go from state-of-the-art basic neuroscience to telemedicine. And I think that and I think there again, we've been lucky to have one of the national leaders in telemedicine. And, I think as, in particular, as we grow into large networks and try to provide healthcare of the same quality across the whole system, and as we particularly have been hit by recent changes in staffing around the country, I think we're beginning to appreciate that we really need to transform not only our science, but also how we approach and deliver healthcare. Michael Hasselberg really has been a national leader in telemedicine. He got his MS as a nurse practitioner at the University of Rochester, and then got his PhD also at the University of Rochester. In 2014, he was funded by New York State to bring the first Project ECHO. ECHO, not like echo in the heart, but the extension for community health outcomes, teleconsultation program into New York State, enabling us to provide behavioral health services to the entire state. Building off of Project ECHO, Dr. Hasselberg has developed several telehealth models, which have been replicated throughout the United States. In his role as the co-director of the University of Rochester Health Lab, he has secured grant funding to further transform care delivery through the use of web-based chatbot applications, smartphone mobile applications, virtual and augmented reality technologies, and the use of artificial intelligence in the electronic health record. He has also been a leader in demonstrating the cost effectiveness of teleconsultation. So it is my pleasure to have Mike Hasselberg show you what the next generation in telemedicine looks like. Thank you.
So when Dean Taubman asked me to do today's talk, I said, what would you like me to speak on? And he said, I want you to tell the secret sauce of how the University of Rochester is becoming leaders in digital transformation and driving us to become a smart health system, a system where technology and data matches the right patient to the right provider at the right time in the right place. And he says, I want you to do this in about 15 minutes in a TED Talk. And I took a step back and I said, okay, challenge accepted. And I was thinking about how am I going to tell this story? And it was actually last weekend, I was watching a movie with my children, a famous movie, Field of Dreams. This is the movie with that famous line, if you build it, he will come. This is a movie about a farmer named Ray Kinsella, who lives in a town called Dryersville, Iowa, home of about 4,000 people. This is a movie about how Ray was seeking life fulfillment in that community, in the community that he described as his home. And to achieve that life fulfillment, Ray did the completely illogical. He cut down all of his crops and he built a baseball diamond. And again, his crops was his family's livelihood. And he did this because an inner voice told him it was the right thing to do. Now, when we think about our community, the Rochester community, we're no different. We all seek life fulfillment in where we call home. Outside of our medical center, there are dozens of Dryersville, Iowas, dozens of communities that look just like where Ray grew up. And there are thousands of people who are just like Ray. Over the years, our health system has started to grow out our reach into these communities. We have set up community hospitals and primary care practices and urgent care practices across this community. And we looked at our data. We looked at the data in these communities, and what did we find? We found that, especially in these rural communities, there are a lot of medical comorbidities. These patients are quite sick. And what we also found was there's really no specialist out in those communities. And so we did something very illogical ourselves. We said, we had this inner voice that said, we need to get specialty services out to these individuals, out to these communities. And I'll tell you why it was illogical. So what we did was we built telemedicine suites out into these communities. And the reason why I say it is illogical was this is well before pandemic times. At this time, telemedicine really wasn't reimbursed. And we said, doesn't matter. We're going to do it. We're going to set these suites up. These patients need it. The other thing it doesn't, why it made it illogical is the way we get reimbursed in healthcare in general. It isn't about keeping your patients healthy in the homes. The way we make money is patients coming up to Rochester, coming into our hospital, keeping our ED seeing patients, keeping our hospital at 110% capacity, and keeping our high-cost providers seeing patients in person and doing procedures. But that did not matter. So we set up these telemedicine suites and we invested in some of the most sophisticated telemedicine technology you can imagine. Telemedicine cards, teleotoscopes, telestethoscopes. We built the most seamless telemedicine software into our electronic health record. But what happened? The patients didn't come. They did not come to these telemedicine suites. So we then said to ourselves, how can we get these patients? How can we give them that nudge so they would come, so we could provide care? So we continued our illogical process. So what we did was we shifted resources into our home care service line. Again, home care in a fee-for-service landscape doesn't make a lot of money, but it didn't matter to us. And so what we did was we invested in some of the most, again, sophisticated remote monitoring tools, wearables, Fitbit, sensors, Bluetooth blood pressure cuffs, and we pushed this technology into patients' homes, hoping by collecting this physiological data, we could then identify when a patient was becoming sick, give them a little nudge to say, hey, you should go to that telemedicine suite. But what happened? Our patients didn't engage in that technology, and they didn't go to the telemedicine suites. So over the years, reimbursement in healthcare has started to shift, where now it's starting to become more logical to see patients in their homes. And I'll give you a prime example. One of the early reimbursement shifts actually happened in orthopedics, and something called a joint bundle. What a joint bundle is if you have a joint injury, as a health system, we get paid a capitated rate from the time you get injured to the time you recover. So Dr. Dean Taubman came to us and said, tell me a little bit about these bundles. What is the most costly part of these bundles? And we looked at our data and we saw after surgery, going to a skilled nursing facility. That's the most costly part. Nobody wants to go to a skilled nursing facility. No one says that's where I'm going to achieve my life fulfillment. So we thought this is the place. This is the place, and we're going to apply technology. People are going to engage, and we're going to keep people out of that nursing home. So we invested in some of the, again, great technology. We invested in gait analysis machines in ortho. We use cool things like taking cameras and use artificial intelligence where we could see the exact angle of someone's arm movement or leg movements while they were walking. We were like, that's going to tell us, that's going to predict who's at risk for falling. That's going to tell us, who's maybe not going to recover well after surgery. But after all of that, and after all that investment, that data did not keep our patients out of the nursing home. It was not the right data. So, we said to ourselves, like, what are we doing wrong? And that was the same question that actually Ray Kinsella had. So when Ray cut down his cornfield and set up that baseball diamond, people didn't come. And the town thought he was crazy. The mystique to that movie was it really wasn't about the present. It was not until Ray addressed his past that he was able to predict the future and get his life fulfillment. So we thought to ourselves, maybe we're asking the wrong questions. And it was actually an orthopedic surgeon who said to ourselves, maybe it's not all this physiologic data. maybe we should just ask the patient how they're feeling. Brilliant, right? And as a behavioral health specialist myself, I'm like, yes, exactly. But where do we begin? And so we went back to our past, our history. 1977, this gentleman here, psychiatrist George Engel, introduced a new model to medicine, the biopsychosocial model. It is us. It is Rochester. It makes us who we are. This is a model that essentially says a patient is more than this, their physiological illness, that you can't treat someone's physical health unless you think about the whole picture, their psychological health, their social health. So we said, that's where we're going to start. We're going to start asking better questions of our patients. So what we did was we built our own technology where we started asking patients at every visit on a tablet when they arrived. It didn't matter if you were coming in for a toenail injury. How was your mood? How was your physical functioning? And how are you doing socially? Every single patient. Now, the University of Rochester, we have the largest patient-reported outcome data set in the entire country in these broad domains. So let me tell you what we've learned. So one of the things we've learned that to keep someone out of a nursing home after surgery, the most predictive variables is their preoperative mood and the level of social support that they have around them. What we learned was that in those rural communities where we set up telemedicine suites, there was significant transportation barriers. That's the #1 disparity that we have in our rural communities. So if you are a rural patient and you will have limited transportation and you got to make a decision, do I use my transportation to go to the telemedicine suite for my cardiology visit, or do I use it to go to the grocery store to buy my food? I'm going to go to the grocery store every single time to buy my food. What we also learned was in these rural communities, there was high level of psychological distress. And so if you've got depression, you're not going to engage in all of those remote monitoring tools that we deployed. So let me tell you what we've done. So we've decided we're going to be smarter about how we deploy our technology. So in orthopedics, for example, one of the things that we built in our electronic health record was an AI tool that tells our surgeon, hey, if you cut today, here's the likelihood that this patient is going to go into a nursing home after. And if you address their mood or their social supports, this is what that likelihood is going to look like. And so now our surgeons are smarter about deploying home care services at the right time. We've also deployed behavioral health tools in surgery. We have VR headsets that we put on patients before surgery to teach them mindfulness, meditation, to help address those psychological issues. What we've done in those rural communities to get behavioral health services out, as Dean Taubman said, we have now one of the largest, most successful telepsychiatry programs in the country, in New York State, and we invested heavily. We could get behavioral health resources in those communities that would have downstream effects on their physical illness. The other thing that we have learned is we need to be more thoughtful about where we deliver telemedicine. So pandemic hits and people are probably thinking, well, why can't you just deliver telemedicine on someone's phone in their home? Well, let me tell you this, and I'll tell you the reason why. It is not because of broadband issues. We actually in the state of New York have really good broadband in these rural communities. It's that the patients can't afford the internet in their home. So the only internet that they're relying on is the data plans on their phone. And if you deliver a video conferencing feed to a data plan on the phone, you're going to kill it. So I'm going to tell you what is, in my opinion, the most disruptive thing that has happened across the country in healthcare over the last couple of years. And it's not Amazon, and it's not Walmart Health, and it's not CVS Health or Best Buy. July of 2021, Dollar General announced that they've hired a chief medical officer. Now, to me, that raised my eyes. I said, that is brilliant. Now, let me tell you, we geocoded our patients. We know outside of Rochester, 85% of our patients live 10 miles or more to the closest telemedicine suite. 85% of our patients live within 2 miles of a Dollar General store. And so now we're thinking differently. We're thinking about partners. Who can we partner with so we can catch these patients on their daily journeys to deliver care? So getting back to that original question of what is our secret sauce at Rochester and how we're becoming leaders. To us, what we learned was if you ask the right questions, it produces better data. Better data produces better insights. We term that now as being Rochester smart. Thank you.
Next question. Why did I think that you would have a question? Let's give you
So I presume that one of the advantages of bringing them to the Dollar General store is that they don't need to have a laptop that has all of the apps and software updated. And Ray Consika's mother doesn't know how to operate Google Zoom or something like that, because presumably you can have stations there where they get instructions to just press this button and it works.
Exactly. And there is broadband and internet at that Dollar General store. So if you can't afford it on your phone, and you're already going to Dollar General to get your groceries, to get your clothing, to get your needs in these rural communities, what a great place to also deliver healthcare. So yes, no one's really sure yet what Dollar General's strategy is. I've had the opportunity to have several conversations with Dr. Wu. I've told him about all the great work we're doing at Rochester, and I said, we would love to explore partnerships. So to me, that would be really cool to put a kiosk in the Dollar General and see patients as they go to that store.
Ruby.
We're still old school. People are still old school. People are people. And we have to remember that when we took our oath, we said, do no harm. We're in this for you. Everything we're talking about here is about money and is about opening this and that. We as physicians have to remember the patient is number one. Now, God puts everybody in a position for a reason. My work is 100% teleradiology now, and it's breast work. By default, because I physically at the age of 76 couldn't drive 4 hours a day. And the U of R very nicely said, look, can't do it. Doctor says can't do it, remote. You can still be successful, but you have to take time. There's the telephone. If the patients don't like coming to a Dollar General or to a kiosk to sign in, they want you. They want us. They want us because they trust us. Take time with them. Pick up the phone. Tell the tech, put the patient on the phone. That is what is important. That's how services grow. It doesn't grow by you putting in computers. It grows by us taking time with each and every patient, which is possible by telemedicine, because I do it every day.
I appreciate your sentiments.
And the services will grow. They will not grow by you putting in more computers. They will grow by you having us, by us having the heart to take the time to speak to every patient who needs it. And they always say, thank you so much. And we should always tell them, as I tell them, you never have to thank me for what I do for you. I do it because I want to. And they love that.
And I could tell you're from Rochester because that's exactly what we found. And so the moral of that story, it wasn't the technology. It's nothing about the technology. It was getting back to our roots in the biopsychosocial model and understanding who our patients are and what they need. And when we really embraced that, the technology was just secondary. And now we're delivering superb high quality care across the entire region. And very excited. We just this month, to toot kind of our own horn, We had a New England Journal of Medicine published, two, actually in the same journal this month about this work and how we're reaching really underserved patients. And again, we're successful because we think about that whole patient. So I really appreciate your sentiments.
Yeah, I would say one other thing, so we have to move on, is that what he didn't show you is the map of where this is going, and it's really virtually all of upstate. What we're finding more and more is that the U of R is the hub for all of upstate. And this has provided a way of getting behavioral health services all around the state, and the state actually gave us a grant to do it.
Mhm.
So, and thank you,
Thank you.
Michael.